Hello students, this is Dr. Lisa Pullen. I'm going to be recording the lectures for this week in regards to anxiety disorders and mood disorders. And of course our focus will be on treatment. I hope everyone had a nice Labor Day holiday. I would have typically recording on Monday, but since it was a holiday, I'm doing that today. I have treated a lot of anxiety disorders and mood disorders. You will see a lot of that. Of course, depending on where you practice, will depend on obviously how many, people you're going to be treating with anxiety mood disorders. So, we're going to talk about social anxiety disorder or SAD. We're going to talk about panic disorder. We're going to talk about agoraphobia and generalized anxiety disorder. So your assessment and clinical presentation, this is just a review. There are several questionnaires that can be used, students, for anxiety disorders. It is an objective measure. They give you a score, and you can have that to validate, when you do your initial evaluation, that you do have these questionnaires. I would not only use one, but I would use a combination. And I've used several of these. I've used the Social Anxiety Thoughts Questionnaire. I've used the Hamilton Anxiety Rating Scale. I've used the Leibowitz Social Anxiety Scale. And I've used the Panic Attack Symptoms Questionnaire and the Complex Trauma Questionnaire. And you, of course, would have an accumulation of scores. And that would give the patient objective findings that in fact they do, based on your initial evaluations and your signs and symptoms that your patient has shared with you. And sometimes, people in mental health that seek mental health, especially with anxiety disorders, aren't comfortable talking about anxiety because these people look normal. They're not like, our patients that might have thought disorders, that have psychosis, hearing voices. So a lot of your patient students with anxiety disorders will wait years to seek treatment and can be in denial. So this would give you, objective measures. So medical causes of anxiety. I recall going over all of this your first semester. It's like, what doesn't cause an anxiety disorder? So it's like finding the needle in the haystack with all the different neurological, CV and circulatory, and somatic. You will find that a lot of people who have anxiety disorders do have, a lot of these symptoms, especially somatic. Migraine headaches, irritable bowel syndrome, peptic ulcer disease. Of course, people who have panic attacks, they feel like they're having a heart attack, and they will often spend a lot of money, even money out of their pocket, since insurance will not cover tests, to find out that in fact it's anxiety, it's panic disorder, and it's not a medical condition. Medical causes of anxiety, it continues. Like I said, it's like finding the needle in the haystack. What doesn't cause anxiety? The endocrine disorders, the inflammatory, and the deficiency. So students, you can do, medical testing to see, if patients have any of these medical causes of anxiety. You always want to check the vitamin B12, the folate level of your patients who present, with anxiety, depression. Medical causes of anxiety. So many medications, as you can see, causes anxiety. Substances causing anxiety. I don't know any that do not, cause anxiety, but that is your list. This is all a review, and that's what the first slide indicated. Assessment of panic attacks. They usually last 5 to 20 minutes with peak intensity of anxiety occurring about 10 minutes after first symptoms, with waves of panic attacks perceived as continuous. Students, your patients will feel like they are smothered. They will feel like they're having a heart attack. Just teach them assertiveness training. Tell them to tell themselves, I am only having a panic attack. This is only going to last 5 to 20 minutes. This is not going to cause me to die. Encourage them to take deep breaths, because sometimes, they can hyperventilate. Sometimes people have breathed into paper bags. You have probably seen that when people are having panic level anxiety because of their carbon dioxide levels. So let them know that it is only a panic attack, that this will be over with, that they're not going to die from it. Triggers, events, certain events may trigger smells, places, memory, or even situation or person. The timing and setting. Some people only have students panic attacks at night. Social settings, that can be one of the big triggers. Upon awakening when alone. Panic disorder, the etiology theories, students, as I have indicated, I remember going over all of these slides your first semester when we've just focused on assessment, risk factors, etiology. So this is just a review that you can certainly, look at to refresh your memory. Social anxiety disorder is characterized by a fear of social or performance situations in which the individual may experience embarrassment. You see blushing. That's a common symptom, students, of people who have social anxiety disorder. Some textbooks refer to it as social phobia. They often have poor social skills, such as making eye contact, initiating conversations, responding to others. It's very hard for people with SAD to get up in front of a group, be on stage, do presentations, especially to their colleagues, engaging in or use of safety behaviors, limited social fear, discrete or fear of many social situations, academic settings. Like I said, presenting in front of your colleagues, I think is one of the most difficult. Employment. And you see the symptoms of anxiety that I mentioned. People feel like they're having a heart attack, especially with panic disorder. But you see similar symptoms with social anxiety disorder: the heart palpitations, the racing heart rate, tremors, sweating, shaking of their hands, diarrhea, blushing. I mentioned blushing, confusion, dry mouth, nausea, or even tearfulness. So this is other information that we reviewed your first semester, second semester. Agoraphobia. Students, you can have panic attacks with or without agoraphobia. Generalized anxiety disorder, the primary feature is excessive anxiety. You probably know or have seen patients in practice that they worry about things before they even happen. You see everyday things such as work, finances, health, repairs, tardiness, social acceptance, and marital adjustment. The degree of worry, students, is out of proportion to the likelihood that something adverse will happen to the impact if something does occur. They believe that they have little control over their emotions and worrying. They have hypervigilance and multiple somatic symptoms. Look back at that slide that showed the somatic symptoms, the migraine headaches, diarrhea, constipation are one of a few. Associated symptoms of GAD. You have your biological, psychological, and social. You have your etiology. And now let's focus on this semester, the treatment of anxiety disorders. The goal of treatment, students, is reduce frequency and severity of panic attacks. We may not ever be able to eliminate, panic attacks in our patients. Reduce morbidity. Patients with panic level anxiety, they get behind cars and drive. They do work-related activities that are a risk, especially if they're having panic attacks. You want to improve their global functioning. Students, we talk about holistic health care. Panic attacks, mental health disorders, as I've spoken, can affect our medical health, our physical well-being. The treatment plan is based on developmental level, stressors, conflicts, social support, and living situation, which, if you look at Abraham Maslow, is based on basic needs. Look at his pyramid. The management of panic disorders includes psychopharmacotherapy, psychotherapy, and psychosocial interventions. And then you have the panic disorder treatment outcomes. Treatment addresses 5 core problem areas: symptoms of panic attacks. What did I say earlier? A patient has all those symptoms of heart attack. Anticipatory anxiety. They anticipate that something is going to cause them to have anxiety. They have phobias related to the panic attacks. It may be, getting on an escalator or an elevator. It may be being out in public. They may have agoraphobia, fear of crowds. It affects their overall well-being. It's an impairment of functioning. Treatment outcomes can be measured with the Panic Disorder Severity Scale. And student, that is a good scale. If you want to use that, it doesn't take long. The patient can answer that while they're sitting out in the lobby. If you feel like you don't have time, I do hear providers say, I don't have time to do these questionnaires. But you could have the patient to fill these out before they come in the office to see you. The treatment of panic disorder medications. Students, with all of our anxiety disorders, we try to use the SSRIs as the first line for managing panic disorders because we know they don't have the addictive potential as benzodiazepines have. We use TCAs, we use MAOIs, and benzodiazepines have similar short-term effectiveness. Again, students, benzos have their place, especially like it says, using short-term effectiveness. Choice of medications depend on the history of the response to medication. Have they taken? That's important to ask students. Have you ever taken Prozac? Have you ever taken Trazodone, which is a TCA? Have you ever taken Marplan or Nardil or Parnate, which are MAOIs? They're our first antidepressants that came out on the market in the early 1950s, then the TCAs, then the SSRIs. Is there potential for tolerating side effects of the medication? Typically, the SSRIs, because they are newer antidepressants, do not have the severity of side effects as your TCAs or MAOIs. However, students, we have patches now for the MAOIs. Several people have done well on those patches that release the medication slowly, that haven't had the side effects, but there are a lot of restrictions with their MAOIs. And that is, you have to avoid any foods, any medications, especially co-medicines that have tyramine, because that can cause an antihypertensive crisis if a patient's on an MAOI. The TCAs, several of those really are used with people who have anxiety that have insomnia, like Doxepin, Trazodone. Then the presence of comorbid psychiatric or medical illnesses. You have to take that into consideration, when you're prescribing the medication. You have to think of substance abuse. Now, would you want to prescribe a benzo if a patient has a history of substance abuse? No. And then what are the presenting symptoms? You know, what are you feeling today? I know you said over the last couple of months you were having these symptoms, but what are you presenting with today in the office while I'm talking with you? Or like the last, 24 to 48 hours. Benzodiazepines for panic. Prescribe SSRI when using a benzodiazepine. When initiating an SSRI, activating properties of the SSRI, agitation, jitteriness, and insomnia may be alleviated with very short-term use of a benzo. And that's up for grabs, really. If a patient does have a long history and has an SSRI on board, and they're still having a lot of agitation, they're having insomnia, I typically will try maybe a TCA like trazodone. But yes, Klonopin, because of its long half-life, I have used that, which is a benzo similar to Ativan and Xanax, but the difference in Klonopin, it has a longer half-life. Have used, and it has really been the benzo of choice to use with anxiety disorders. Clonazepam or Klonopin. Concomitant benzodiazepine should be tapered to discontinuation after 4 weeks of antidepressant. Use a 3-week taper schedule. Again, students, it does depend on the dosage of the medicine, the age of the patient, how long they've been on the benzo. Sometimes I get referrals of patients whose primary care has had them on a benzo for some time. You have to look at age. Again, you have to look at the amount of the milligrams, and your taper may have to be longer than a 3-week taper. That's just referred to as individualize your plan of care. We use that terminology throughout your syllabi. Your plan of care needs to be individualized, students, for your patients. It's different with most all patients. CBT, cognitive behavior therapy during withdrawal from benzodiazepines and antidepressant medications can reduce the risk of rebound panic. We know from research that psychotherapy, especially CBT, in combination with med management, is the evidence-based practice for treating anxiety disorders. Benzodiazepines are often for management of acute anxiety and panic attacks when these do not resolve with antidepressants alone. Low-dose PRN use, alprazolam or Xanax or lorazepam, which is Ativan or clonazepam, Klonopin are most common. I've typically seen Klonopin in my career or clonazepam used mostly. Benzodiazepines for panic. The effectiveness of benzo students is not as wide. Problems associated with the use of benzos include dependence and cognitive impairment. I said that earlier. Xanax has been reported to induce mania. You can see that, students, and I have worked in geropsych and long-term care facilities where Xanax has really triggered what we call a paradoxical reaction in a geriatric patient, which does cause extreme anxiety, mania, just a different effect, paradoxical opposite effect. Clonazepam may be preferred to alprazolam. It's longer acting, like I've said, so it's less dangerous. There's less risk of the patient experiencing withdrawal symptoms. It blocks panic attacks, and it's been found to have other benefits such as improved quality of life and increased work productivity. And I do have patients on occasion that have had issues with anxiety most of their life that do well. They're very productive. They have a great quality of life taking a low dose, benzo. And we monitor those. I check the control database every time I see the patient. I do pill counts. We do drug screens, just a few things to make sure that the patient is taking it, that it's not being abused, or the patient's addicted to it. If the patient is doctor shopping, if they're requesting refills sooner than what is reflected on the controlled database. Needless to say, I confront and discuss with the patient, what has caused you to do this? And go from there. Addition of clonazepam to SSRI speeds up treatment response. Antidepressants for panic attacks, panic disorder. Some patients report sensitive to antidepressant medications. You educate your patient about these sensations and that they do not signify a panic attack. You avoid patients' early treatment, termination of treatment. You start with low dose, lower than MDD dosing, increase dose by small amounts every 1 to 2 weeks. Phone call, follow up approximately 1 week after each increase, prevents focus of worries about side effects being severe enough to call. Educate about expected benefits, begins at least or equal to 4 weeks, but may take 8 to 12 weeks for full response, and that treatment should continue for 8 to 12 months to reduce risk of symptom return. Students, I've lived by the philosophy, if you can, start low and go slow with your taper, especially if you have a geriatric patient. If you've got a patient in an acute crisis situation, that might be different. You may have to go ahead and start an SSRI at a higher dose, because we typically have to use higher doses for treating anxiety with SSRIs. But I may have to start a benzo for a couple of weeks until the antidepressant is effective. And I do adhere to what is on this slide. But again, you have to individualize it for your patient and their situation. Use of antidepressants for panic disorder. In summary of the use of antidepressant medications for patients with panic disorder, full remission of panic attacks usually requires 4 to 12 weeks of treatment. Patients should be kept on full dose for at least 6 months to prevent early relapse, and after 6 months, dose can be tapered to 1/2 dose of medications, and then gradually the dose can be reduced every few months until the minimal dose required to keep patients symptom-free is reached. Totally support that. Again, you do have to, though, individualize it according to the patient's needs. SSRIs for panic disorder students. I have used all of these with the exception of Luvox. I have used that once or twice early in my career. It has a lot of drug interactions. It was really marketed to help with anxiety. However, I've never, and colleagues I've talked with haven't had that much success with it. However, you may have worked with, some healthcare providers that have. Cost and previous response to medication may guide selection of a specific SSRI. And students, don't take that lightly, cost. Some of our patients have difficulty, buying food, as expensive as food is, and living. So you do have to take that into consideration. Then the serotonin 2 receptor or serotonin 3 receptor antagonist may limit symptoms of insomnia, agitation, or gastrointestinal distress. Well, I have used Remeron, especially in a geriatric population. It really does seem to help with their insomnia and their agitation. I have not used Zofran, which is commonly used for, a nausea medication. I've also used trazodone. I have used doxepin. And there's medications like Restoril, Ambien. But of course, you would want to monitor the controlled database if the patient has not got a history of substance abuse. I'm conservative with med management. And I always do counseling with my patients and add the counseling psychotherapy code. I try to max out personally most of the time the dosage of a medication. However, you will become comfortable with your own prescribing practices. But fewer medicines, if I possibly can, is what I prefer. and it has worked. I have a patient population that I have worked with for many, many years, and I've gotten to know my patients. And again, they all do psychotherapy with me, and then some I refer out that need additional psychotherapy. TCAs for panic disorder. They are effective as the SSRIs in treating panic disorder, but not widely used. Because like I said, they're next to the oldest antidepressants. The MAOIs are the oldest. And what did I say? They have more side effects, or SSRIs. Every time a new medicine comes out, hopefully it does a better job targeting the symptoms and fewer side effects, students. But some of the side effects with TCAs are cardiovascular problems. It can cause an increase in blood pressure, weight gain. It can cause sedation. But that's why sometimes we do use trazodone, for example, if you've got a very anxious patient that has insomnia. And the nice thing about trazodone is you can start out very low dose. It has a huge window of dosing, milligrams. I would typically give the geriatric patient like 6.25. Sometimes I would use a 12.5. You half the tablet, twice. My patients that are in the outpatient clinic that are younger, I may start out with 25 to 50, go up to 75, high as 150. You can go up to 300, 450. I had a patient years ago that came to me on 600. Needless to say, over time, I was able to decrease that dosage, because really the average daily dose should be, or evening dose should be, 450. And then the TCAs are potentially lethal, the lethality in overdose. So students, you would not want to give the patient, refills, a 90-day supply on this medication, especially if they're depressed, if they're suicidal, if they have a history of suicide. You would want to follow up with the patient within 2 weeks when you prescribe. Some people, colleagues, will tell me, well, within a month, but I follow up within 1 week to 2 weeks if I start the patient on a tricyclic for, insomnia. So you have anafranil, tofranil, norpinephrine, and Pamelor are the second line of treatment due to intolerability of side effects. To be honest with you, really the only one that is commonly used is tofranil. Anafranil, marketed again for anxiety disorders, really did not achieve the effectiveness that we thought that it would. Norpinephrine and Pamelor. I had a patient who had been on Pamelor by her primary care doctor for 20, 30 plus years. You can check a blood level on that. He never checked her blood level. She started falling down, was disoriented, slurred speech. I was asked to consult, on her case, and it was like finding a needle in the haystack. But when I saw that she was on Pamelor and had never had that blood level checked it, and it was 3 times higher than the therapeutic level. Stopped the Pamelor, and within 24, 48 hours, the patient was back to her normal baseline. When using TCAs, continue for 18 months or longer is associated with reduced risk for symptom return. Augmentation medications for panic disorder affects or reduces the number of panic attacks and improves anticipatory anxiety, fear, and avoidance. Although I have had patients who say it makes them more anxious. Buspirone, used as a scheduled or PRN med for milder panic. I have often used buspirone. The effectiveness has been, okay. Some patients love it, some patients hate it. There's really no in between. You have your clonazepam, your Klonopin, Anticipation anxiety situations when panic may occur. Olanzapine or Zyprexa is associated with 75% decrease in panic attacks and anticipatory anxiety in patients who had not responded to other forms of treatment. The only thing, students, with Zyprexa, is the metabolic syndrome. You really have to monitor the blood pressure, the blood sugar, and the patient's BMI. Panic disorder medication and therapy. Combination of psychotherapy and pharmacotherapy produces better results than either alone. Early improvement, I've said earlier, psychotherapy and pharmacotherapy is the best evidence-based practice for anxiety disorders. Early improvement is evidence that if medication is used alone, improvement in anxiety, sensitivity, social avoidance, and disability, does improve. While waiting for the benefits of combined treatment, benzodiazepines may be used for severe panic attacks or high levels of anticipatory anxiety. And I have said that. Sometimes I said I will start an SSRI, but if they have severe anxiety, panic level anxiety, you may have to start a benzodiazepine for 3 to 4 weeks to give that. And sometimes it's 8 to 12 weeks, like that slide said. But you monitor, again, for abuse and dependency. Cognitive behavior therapy, that's pretty much the psychotherapy treatment for most disorders. This is what insurance will pay for. Most therapists are trained in CBT, although many are trained in other types of therapy, but particularly CBT. It focuses on the patient's experience of anxiety related to panic and somatic sensations rather than avoidance behaviors. The intensity of therapy, the number of sessions and interventions used is associated with the degree of improvement. Of course, weekly sessions are over typically 12 to 15 weeks. You have to authorize if the patient needs more sessions. Cognitive behavior therapy includes, students, you can see these 5 things that are listed. Then other psychosocial interventions for panic attack. Students, marital and family therapy. I'm fortunate to work at a facility that has a marital and family therapist. A lot of times it's family discord, marital discord, relaxation therapy, breathing retraining, bibliotherapy, which, involves writing. It involves educational materials, to educate, which is included in under education. I think nurses, I know nurses. We educate our patients and we don't give ourselves enough credit for that. Combined treatments, evidence-based studies suggest that there is a modest short-term advantage for combined treatments. Treatments of social anxiety disorder. The goals, students, are these 4: reduce or eliminate the symptoms of fear, reduce or eliminate avoidance behaviors, reduce or eliminate physiological distress, improve functioning and quality of life. Treatment includes psychotherapy, pharmacotherapy, and psychosocial interventions. Students, let me stress again, we should be providing holistic health care, which should include psychotherapy, pharmacotherapy, psychosocial interventions. Does everybody need pharmacotherapy? Not necessarily. They may benefit tremendously just from psychotherapy or counseling and or psychosocial interventions. Medications for social anxiety, generalized SAD, SSRIs and SNRIs are first line of pharmacotherapy for generalized SAD. Just like panic disorder, treatment is often started at half the usual dose and increased after a week. Response rates are 50 to 80% after 8 to 12 weeks of treatment. Patients who respond by 12 weeks should receive maintenance treatment to reduce risk of relapse. Higher dosages of SSRIs may be required for SAD in comparison to the doses used for major depressive disorder, panic disorder, of generalized anxiety disorder. Venlafaxine, which is effects or extended release, the reduction of anxiety symptoms and improvement of their social life at 4 to 12 weeks and better work function at 12 weeks. Second line medications for social anxiety. I talked about Remeron and Buspar already. Cautious use of benzos when SSRIs or venlafaxine, because people can dependence can develop in 2 weeks on use of benzos. Use of longer acting benzos can reduce risk of dependence, such as clonazepam or Klonopin. Bupropion and tricyclic antidepressants have not been found to be effective for social anxiety disorder. Treatment of non-generalized SAD, performance anxiety. Students, beta blockers are the first choice. Metoprolol, Lopressor, Tenormin, or atenolol, and propanolol, Inderal. It helps reduce the autonomic arousal, the tachycardia, palpitations, tremor, sweating, flushing, and dry mouth when taken 2 hours before a performance that is anticipated to cause anxiety. Benzodiazepines can reduce performance anxiety. Take 30 minutes before a performance. Yes, I have patients that I will order one-time dose of a benzo if they have a performance, if they have a procedure, may impair performance due to side effects of sedation and cognitive dulling. If the problem is ongoing, an SSRI should be used. Psychotherapy for social anxiety, cognitive behavior therapy, exposure therapy. Students, hopefully you have already read what exposure therapy does do, for people with anxiety disorders. Exposure treatment provides an opportunity for the patient to experience correct information that may modify dysfunctional beliefs. More effective than progressive relaxation training, and a combination of cognitive therapy that addresses the fear of negative evaluation by others, and exposure-based interventions that involve repeated confrontation of the feared situation until it no longer produces anxiety, appear to be the most effective intervention with the longest lasting benefits for SAD. Social skills training and relaxation for social anxiety. A lot of times our patients lack social skills. This is really a psychosocial intervention. So look at that, the relaxation strategies. I work with, again, therapists that teach our patients, progressive relaxation techniques. Pharmacotherapy for generalized anxiety. Students, it's some of the same medications that I've already talked about. It's usually the effectiveness, the response to the medications is usually within 8 weeks for generalized anxiety disorder. Treatment is usually continued for 6 to 12 months. Some patients may need to be on medication longer. Because of the long-term need for pharmacotherapy, SNRIs and SSRIs have become the first-line pharmacological intervention. In the treatment of generalized anxiety, Buspar is effective in 80% of benzodiazepine-naive patients for psychological components of GAD, but may be less effective in decreasing somatic complaints. Remember, I said earlier, a lot of your patients with generalized anxiety disorder have somatic complaints, may have no antidepressant effect. Response may take 2 to 4 weeks to show effect, causes little drowsiness, memory impairment, or sexual dysfunction, and does not cause dependence or withdrawal symptoms. First choice for is a history of substance abuse, pulmonary disease, who operates heavy equipment such as trucks or airplanes. You would want to consider Buspirone or Buspar. Benzodiazepines for GAD. Benzodiazepines are effective in the acute phase and for physical symptoms of anxiety. Strongest effect is on hypervigilance and somatic symptoms, less effective in relieving symptoms of dysphoria, depression, and anguish, interpersonal sensitivity, and obsessive thoughts. If benzodiazepines are to be withdrawn, the dose is decreased over 3 to 6 months. Relapse rate is 50 to 70% during the first year after withdrawal of a benzodiazepine. SNRIs would be venlafaxine, students, and Cymbalta or duloxetine. First-line treatment of GAD and FDA approved for treatment of GAD. Response rate is about 70% with benefits evidenced by 2 weeks for anxiety, but longer for somatic symptoms. Effectiveness for insomnia, restlessness, poor concentration, irritability, and excessive muscle tension. SSRIs for GAD would be fluoxetine, Prozac may transiently increase anxiety. Paroxetine or Paxil and sertraline, Zoloft do not increase anxiety. Paroxetine has been found to reduce anxiety symptoms, reduction of anxiety evident after 1 week, and to improve social functioning of patients. The escitalopram, Lexapro, 68% showed improvement after 8 weeks. Other antidepressants for GAD, again, mirtazapine or Remeron, 50% improvement occurred in 80% of patients. TCAs such as empramine, tofranil may be used to reduce symptoms of GAD, and they may be useful in managing the discontinuation of benzodiazepines. Side effects that may limit their use, such as weight gain, orthostatic hypotension, urinary retention, constipation, and sedation. There is also a problem of lethality of overdose. Bupropion or Wellbutrin is avoided for anxiety disorders as it frequently increases anxiety. Yes, I've had that experience with patients who come to me that have been put on Wellbutrin for depression, but they have a lot of anxiety and it's caused an increase in their anxiety. Other medications used for GAD, anticonvulsants. Some have anti-anxiety properties. They are useful for patients with a history of substance abuse or for patients who cannot tolerate antidepressants. Gabapentin or Neurontin has been found to be useful. Beta blockers are useful for palpitations, sweating, and tremors. Can be added or used as needed for performance anxiety. Psychotherapy for GAD, again, CBT. The greatest benefit students are usually achieved after 6 months. You have to take into consideration, students, especially with GAD, these patients have had anxiety for a majority of their life. There's not a quick fix. It's going to take years of psychotherapy and typically med management. About 40% of patients receiving CBT experience recovery and 60% are improved. And that's so true with your patients with, GAD. Psychosocial interventions for GAD, promoting healthy lifestyle practices by encouraging students. These 6 things that we certainly could all benefit from. You need to teach these people. It seems simple, but they don't have problem-solving skills. They need to have work on social skills, how to use anticipatory guidance, how to use effective communication and stress management strategies. Relaxation therapy for GAD. You can see